Okay, in this chapter 7, then we move on and we learn about the different montage settings, viewing a polysomnogram. Remember, a montage is just a organization of the recording equipment that you're using. So the example I have here, we have the right eye on top, the left eye in channel 2. The third channel is the frontal lobe matched to the M1 that's behind the left ear. In the fourth channel, our exploring electrode is C4 and our reference electrode is M1 again. In channel 5, we have our occipital lobe on the right as our exploring electrode, and we have our reference electrode to M1. Next, we have an EMG, that's an electromyogram channel, that's our chin, and notice that looks like a thick black line, and that's because that pen is moving so fast up and down, or our recording is moving so fast up and down that it looks like a solid black line, and really that's because there is just so much activity coming from the chin muscle. Next we have our EKG, and I can clearly see my P wave. My QRS is all kind of melted together there, and I can see my T wave there at the end. Next I have my right leg, another EMG channel, and my left leg, again another EMG channel. Then I have my snore sensor. Next I have my thermistor, then my pressure transducer, followed by the respiratory belt around my chest, and then next is the respiratory belt around my abdomen, and then lastly we have our oximetry in the very last channel. So we could rearrange this montage any way we wanted. We could put our airflow signals way up at the top, but based on how we score studies and how we know when our patient's awake and asleep and our response to changes throughout the night, this is the standard way that the montage is set up. You might be at a sleep lab where they actually put all the EEG channels in the first 4 channels, or excuse me, first 3 channels, and then they put the eyes and then the chin. But basically the montage usually has all EEG and EOG at the top of the screen, very close to the chin, and then the respiratory stuff is usually on the bottom. In this section, this is where we also talked about the eyes, and remember the cornea is positive, the retina is negative, so whichever way the positive electrode moves to another positive site, so if your left eye looks to the left, that's where your positive electrode is, or positive part of your eye is closest to your electrode. That is going to create a positive deflection, meaning that electrode, the waveform on your channel is going to go downward. In contrast to that, the other eye, where there is a negative charge closest to the electrode, that is going to have a negative response, which is going to be an upward deflection on your polysomnograph. So I know the eyes were very confusing. I think everybody got them straightened out. But again, if you have questions, please let me know. Let's go on.
Display layout. The polysomnogram is recorded with a series of channels. Each line of data is a channel. Channels are labeled from top to bottom, with the topmost channel listed as channel 1, the second line is channel 2, and so on. You can see it in the picture next to us. In this example, this sleep center has the eyes on top, so it goes right eye, channel 1, left eye, channel 2, frontal lobe, channel 3, central lobe, channel 4, occipital lobe, channel 5, and so on. This sequence of channels is called a montage, and later we're going to talk in another chapter. We're going to talk about the filters of the montage settings, but this is just our display, the channel display. And the order of these, as I mentioned before, can differ from lab to lab.
Okay, so in chapter 7, not only did we figure out kind of what we're looking at on our polysomnogram and what the eyes do and what it means when they go up and down and how we tell the difference and whatnot, but I just wanted to review what the different other channels look like. For example, look at our chin, and if we were looking Starting at the left side of your screen and then moving your eyes towards the right, you see the chin is smaller on the left. We call this more relaxed or quiet. And then right at about second 5, we see it increase a little bit. And then we really see it increase again right about second 8 and 9. And you see that line get thicker there. So what's happening when that line gets thicker is it could be the patient swallowed, or it could be they're just awake. And so remember, when you're alert and awake, you have higher muscle tone, because when you fall asleep, those muscles relax. So the chin is a really good place where we can tell when someone is relaxed, and when they are having higher muscle activity, which corresponds with them being awake. Going down to the right leg channel, we see one little right leg movement that isn't very big, and it's not even long enough for us to actually score it, but that is what a leg movement would look like. If you look down on the snore channel right around second 4, that patient probably snored at that point in time. And now I'd like you to go back up to your EEG and EOG and start at the right of your screen and then move your eyes towards the left. And what we see initially at second 1 there, that patient is actually probably asleep in stage probably 1. And then right about second 5, they actually have an arousal, and that actually looks like a K complex. And a lot of times you see a K complex right before an arousal, just like in this example. But then you see the brain activity, especially in O2, you see quick alpha waves there. And the alpha waves last from second 5 to about second 9, and then it kind of starts to slow down again. And then by second, I would say 12, that patient is asleep again. So we see about a 5 to 7 second arousal here. And you see how the chin activity increases as the patient has a brief arousal. So this is just an example of the things we are looking at and the things we're going to continue to look at. It was around this time in lab that I had you all enter the AASM scoring site and start to just view polysomnograms. I just wanted you to get familiar with what they look like and how, not that you know the different stages, but as you progress through the study and through the epochs, to how those waveforms change throughout the night. Okay, let's go on. Here are some examples of some respiratory signals. I want to make sure we all look at this together too. We have the thermistor. It is, I have that channel outlined in red, or a couple breaths outlined in red actually. And at second 3, and that's right where my red box starts, that is right where inspiration begins, or just before inspiration. There's a pause, and then as you see the line move upward, that is the patient taking a breath in. And then it reaches its peak, that is the end of inspiration. And as you see the line go back down the other direction, that is their exhalation. And you see it gets to a point at the bottom, which we call the nadir of the waveform, and there's actually a pause at the end of exhalation, and then it goes back into inspiration. And when it reaches its peak, notice there really isn't much of a pause when you take a breath in, and then it drops back down into exhalation. Now, as long as the patient is breathing normally, you should see this type of movement pattern in the thermistor, the pressure transducer channel, the chest, and the abdomen belts. So going on now, look to your purple square, and here, this is the nasal pressure transducer. This is the first channel we're going to look at when we're trying to identify a hypopnea or a RERA. And this channel needs to reduce by 30%, and we're not scoring yet, but I'm just giving you all the information I can. And it is more sensitive to the shallow breathing. Now, if you look back to your thermistor, which I had outlined in red and we already talked about, that channel is the first channel we're going to look at to identify an apnea. Now, actually with an apnea, you should see flattening in both the thermistor and the nasal pressure transducer. With a hypopnea, your thermistor may look normal, but you should see a definite decrease in your pressure transducer. If you do not see a decrease in your pressure transducer, then you cannot score it. If you see a decrease in your thermistor and not your nasal pressure transducer, then you probably need to adjust your sensitivity. Okay, now let's move on to the green box. These are your chest belts and your abdominal belts. And you notice these don't actually line up well with our thermistor and our pressure transducer. And they really should. The reason why they may not is sometimes with chubbier people, sometimes there's a little delay in the response of the belts to them breathing. So that could explain the situation. Other times, maybe when they did the BioCal, they were inverse of what they were supposed to be and they just never fixed it. So my recommendation would actually have been to fix this during the BioCal. These two channels, though, the chest and abdomen movement, these are used to monitor and record respiratory effort. So if you see flat lines in your thermistor and nasal pressure transducer channels, you know the patient is having an apnea. And then to determine if it's obstructive or central, you need to look at your chest and abdominal belts. If those are flat as well, then you have a central apnea, meaning there is no respiratory effort, so no airflow can move in or out of the body. If the flatness is in channels for the thermistor and nasal pressure transducer, but there is continued movement in your chest and abdomen, then this would have to be an obstructive apnea, meaning the patient is trying to breathe, they're using muscle strength to try and take a breath, but something is blocking the airway and preventing air to be moved in and out of the patient's body. The very last item on this one is outlined in a blue square, and this is your SpO2 channel. When we identify a hypopnea is present, this would be the last thing we look at to identify the hypopnea. The first thing we need to see is a decrease in airflow sensitivity, or our airflow signal in the nasal pressure transducer channel. And as long as we see the decrease there, then we look at our SpO2 to find a 3 or 4% desaturation, and that will make a hypopnea. If we see a decrease in our nasal pressure transducer channel of 30%, but we do not see a desaturation of 3 to 4%, and the patient has an arousal associated with it, then that would be a RERA.
EKG, or in this example, it's labeled ECG. It's in the 7th channel down, and you can see the QRS complex. Having this on our polysomnogram allows us to calculate the heart rate in beats per minute, as well as visualize arrhythmias. When we count EKGs, we want to count in 10-second intervals, and since our epochs are 30-second epochs, we're going to count from second 0 to second 10, and then take that number times 6. And then our answer for this is going to be on the next slide. So here is 0, and we're going to count over till second number 10. These blue numbers at the top tell you how many seconds it is. So we're actually going to count backwards just because it's easier. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Let's go on and take that times 6, and then let's check your answer. So we counted 11 beats between seconds 0 and 10, therefore the heart rate is 66 beats per minute. If you're using an ancillary oximeter that's plugged into your polysomnogram for your SpO2, typically those will have their own heart rate on them. Remember that the heart rate on that will be less accurate than you counting the heart rate, and this has to do to the sampling rate that is within the oximeter. When you're visualizing the EKG and counting it manually, that will always be more accurate. Okay, just an overview. Virtually everything that is recorded on our polysomnogram is going to be included into a report in one way or another. So it's very important for everything that you document when it happens and why it happens. One thing I did not talk about yet is body position. Body position, in some labs they have sensors on the equipment, on the respiratory belts, that will record the body position. However, it's best that techs always document this manually. Just simply identifying at the beginning of the night what position the patient's starting in. If they're supine, you type in supine. If they're on their left side, right side, whatever. And each time the patient changes positions, make sure you're noting it when it's occurring during the study. This information, the whole information of the night as a whole, it can be viewed in a text format or it can be viewed in a graphical representation like I have provided here on the right, and this is called a histogram. This is actually several histograms here. The one on the top is of the SpO2, so you get a snapshot of the entire night. This patient went to bed at 11 p.m. or 2300, and it looks like they got up at after 5:09 was right here, so it would have been after that. The heart rate, again, you can have a good picture of the entire night. Next is the sleep stages, and we've looked at blown up one of this before. REM is the level right after awake, so we see this patient maybe hit REM for a brief period at about 12:30 maybe. It's hard to tell right there, but they really didn't get any significant REM until about 2:30 in the morning. And then that's really about all they got that night. Body position, so you have your abbreviations over here. S is usually supine, L is right, or left, excuse me, R is right, P is prone, or they must be using B for back on this one. Strange. Anyway, you can have a good snippet of the night for the patient on that. Down here on the bottom, this is treatment. They started the patient on CPAP at some point during the night. And then down here is all their respiratory events. So OA is obstructive apneas, MA is mixed apneas, hypopneas, RERAs, central apneas, PLMs, and then arousals. And so you have a really good overview of what all occurred for that patient in the entire night.